Welcome to Distance is No Obstacle, a medical education podcast aimed at providing bite-sized education and information for people working in rural and remote Australia.
All right, it's great to be on the podcast. My name is Rowan. I'm the head of complex care and a physiotherapist at Western Kids Health, and I'm here with...
My name's Phoebe. I'm a clinical psychologist at Western Kids Health, and I work within the complex care team there as well.
Yeah, so I suppose a bit of a background from what kind of people we see and, where we're coming from, and then, about the discussion today, which will be on FND. We see across the board paediatrics and adolescents and young adults in the complex care space. So that includes people with pain and functional neurological disorders, connective tissue disorders, chronic fatigue, amongst other different conditions as well, and often supporting them as an MDT, so kind of physiotherapy and psychology, and not in the room with us, OT as well, which is a really, really great kind of space to work in. And today we're going to be talking about FND, specifically for rural health, Western Australia, and what you might be able to read in some of the research that's been coming out over the last few years, and that I guess sometimes it's not something that's presented within studies, so like university level, there's not a lot of information there. So a lot of people come out, and especially working in a generalist space, we kind of see that it's not something that's forefront of mind, or a lot of information, and there's been a lot of change in it too. So what we'll start with is just chatting a little bit about FND in the rural health kind of space. We do see that it's quite prevalent in minority groups, in lower socioeconomic spaces as well, and we'll talk about why that might be from like a stress response perspective when it comes to cognitive stress, financial stress, and all those different parts to how it can impact a person, and then how someone understands healthcare as well. Because health literacy and the health scaffolding around someone is really important when it comes to the presentations of FND. We'll touch on a few really interesting parts that I think is just, really, really fantastic in the evidence at the moment, and that's about early recognition of FND, how important language is, and I guess from that, the first point of call when they present to someone in healthcare, how important that can be, and that might be you. So as a health professional, your kind of first line, and there's a lot of info that will be presented today that's really helpful on managing FND.
And I guess we're also thinking about this in the kind of rural context. Obviously, people who live in rural areas have, we acknowledge that they have a bit more limited access to particularly tertiary services or kind of specialised services. So I suppose we're kind of thinking from that lens of the importance around the words that are used and the treatment that occurs kind of really early on in the piece, where even if you don't have, an extensive kind of specialisation in FND, where that still plays a really big role before maybe they're referred to a more kind of specialist service.
So we'll dive into it.
Yeah.
We've got a few different topics kind of spread out, and some of that I'll be chatting through, I guess, what we know and what would be really useful for you to know, and then some from Phoebe as well. So we'll dive into it.
Awesome. So what we thought we'd start with is probably the more obvious question, which is, what is functional neurological disorder? So I suppose something that a lot of healthcare professionals would be really appreciative to know is, how, Ron, would you explain functional neurological disorder to a patient or to the family of a patient in a way that's accessible for them to understand?
That's a really good question, and it's often a challenging area because FND does sit in this space of mind and body. Their body is responding in a different way, and so there's a physical presentation, but then there can also be cognitive components to FND too. So it really does depend on what someone's presenting with. We understand FND can present in all sorts of different ways. There's a massive list, and it can be motor difficulties, it can be sensory changes. They might feel pain or loss of the sensation from different body parts, which then also links with paralysis, functional seizures, drop attacks, or drop episodes as well. It can be virtually any kind of system of the body that works voluntarily can involuntarily go wrong with FND. So it's sometimes kind of understanding what's being presented and then explaining it in a way that makes sense for someone. The analogy that I guess I often am attracted to and is used really commonly in the space is a software-hardware explanation. That's because someone is often presenting with some form of neurological type presentation or difficulty. For example, they have a foot drag with walking, so a gait disorder or a gait disturbance, and that would kind of fall in this like functional movement disorder space. And so they're walking in and they've got a foot drag in, they're worried that they're paralysed, they might have had a stroke, or in childhood, parents just going, what on earth is happening? They normally would present either to a GP or an urgent care or an ED and have a lot of investigations done to rule things out. And we'll talk a little bit about that kind of ruling in process in a moment. But they'll often kind of get all of the tests completed and everything comes back fine. So they're left at this space of, well, what's wrong with me? What's still going wrong? The software-hardware analogy draws on that, and we often explain your hardware is working. Your hardware is fine. Your hardware is fine. It's been scanned and cleared, but the software isn't working. So the messages are being scrambled, or the messages from the brain to the body and back are not how we want them to be being sent and processed and interpreted. So that's often a bit of a reassurance. It still does leave that space of like, okay, what now? Which is a good question for patients. But I often explain that, and that's really containing and helpful for people to hear. Like, okay, so there's nothing wrong with me physically, but there's a process that's going wrong, which is causing things to physically go wrong. Which is a nuance difference.
Yeah, absolutely.
One other way that I would kind of explain it in kind of non-technical language is a bit of like a stress system explanation, where everyone has a stress system, and that's really closely linked to their movement system. And when one goes wrong, the other one, or one is activated, the other one's impacted. Like sweating, you can't control sweating, you get kind of stressed, it happens. So that kind of link that we can see that works in the body, and so that stress response and then impacts on the motor system, and even the thinking system too, like cognitive efforts, memory.
I guess that kind of leads really nicely into the next question, which is kind of relates to a lot of people's experiences where they may feel that the implication is functional neurological disorder is kind of purely psychological, and they might have advice to go to talk therapy, and then everything will be okay. And I think we know, obviously, that it's not just psychological; it's neurological. How would you kind of, I guess, go about making that distinction?
Yeah, that's a really good question, and it's something that probably comes up with most people that are presenting with FND. They either heard it or looked it up, and they go, oh, well, it says it's all in my head. Or they've come out from potentially a ED space and been kind of discharged quite quickly because they're not urgently medically unwell, which is great for them, but leaves them in this gap. And so they might be interpreting that as, oh, they just said to go see a psych, it's just psychological. I guess there is the kind of deeply philosophical part of everything being in the mind to some degree and being driven by the brain. But I think when it comes to explaining that to a family or a patient is recognizing that the brain is just part of it, or I guess someone's psychological experience and what's going on for them is one part of it, but it doesn't happen in silo. It's how someone's responding to their physical state. Like it might be that the physical stress has brought things on. There's other different triggers. How someone's going cognitively with so physical, emotional, is obviously that psychological space. The physical side of things and how the brain connects with the body's, it kind of comes in both. It has to have both to it. And so just saying it's psychological is, number one, it's really dismissing for a person often. But we don't have the functional neurological disorder presentation is often that kind of physical space. I'm probably not explaining that to the best of my ability.
No. I guess it sounds like it kind of ties into thinking about things from that biopsychosocial lens rather than just a psychological lens. It's like biology, like in terms of people's biology, what's going on, as well as their psychology and their social aspect of their being as well. I guess one thing that I was thinking, kind of when maybe if I pictured myself in a medical space out in a rural area, would be what kind of things would you say might be helpful to have as a little mental list to flag as kind of further investigating for FND? Like, what would you see that would come into the clinic that would kind of click for you as, I might look into that a little bit further in terms of FND?
In terms of if something being FND?
Yeah.
That's a really good question. In terms of, I guess, those kind of things you might be looking for, even in other different kind of crossover spaces, because we often see FND present with pain or with fatigue, and someone might come into a GP practice or a physio practice complaining of back pain, but then we notice certain parts to it that might be flagging of FND. One is an element of attention shifts changing the presentation, so distractibility. And part of that being the nature of FND is that when someone focuses on a symptom or a body part, symptoms get worse. When they shift their focus off that onto something else, symptoms get better. That kind of motor system gets back in online, or even the way they're thinking. So, speech can sometimes be impacted if they're coming in and it's slurring speech or finding a stuttering. And then when they really get into talking about something, or their kind of mind focuses onto something else and conversation shifts, that starts to resolve and change. That would be a flag for, okay, well, maybe what we're seeing here is more of a functional presentation. Now, that's not to say that is the definitive, it's now FND, but it's a flag to kind of be curious and ask about, well, what's happening in all these different areas and different spaces, and how is that impacting the person? Let's kind of dive in a little bit more.
Okay, so that kind of variability in symptom presentation across an appointment, say, and then if that coincides with distractibility, for example, like maybe they're talking about something they're really interested in, or okay. Big hard-hitting question. Why do you think it's important, and I think this is going to resonate with a lot of people, why do you think it's important that clinicians feel confident saying the diagnosis out loud to patients?
I think it's extremely important that it's something that's done and that someone feels confident in. Maybe not the fact that, this is, not saying this is definitely FND, but it's actually saying, look, what I'm saying has elements of potentially FND here. It doesn't have to be like the certainty of like this is exactly what's happening until later down the track. But even in like early times when you're noticing those things, number one is that it removes the stigma. It's something that is something we can chat about and say, this is something I'm seeing. And the second part is that saying it out loud, which is a little bit different to the approach that's previously been taken. Which, when it was probably classed or considered as conversion disorder, or even prior to that, hysteria, or pseudo kind of issues, or pseudomotor issues, would be the approach of not telling them that that's what's going on, but almost trying to distract them and trick them into recovery, which is a very different kind of approach. And we'll talk about that kind of ruling in process a little bit later. But actually explaining to them, the person that is experiencing the FND or the potential FND is going, look, this is what I'm seeing, and this is now, the plan we're going to make, whether that be refer on or as part of treatment to where it's going, this is FND, these are the reasons why I think it is FND, and this is what we're going to do about it. Because then it becomes about the person feeling empowered rather than kind of working around it with them not in the conversation.
Yeah. And I guess it kind of, it made me think of kind of trauma-informed care principles, which really strongly emphasise kind of partnering with your patient and your client, and that collaboration and also that transparency. So this is what we think is going on in a containing way, obviously, and kind of this is the plan that I'm thinking, and we're kind of going to work towards this together. As you said, instead of kind of working behind the scenes and tricking people into getting better, I suppose.
Yeah, that's right. And that early conversation of, well, this is what I'm seeing, this is I noticed when your attention shifted over there onto that, you were able to bend down really easily, and like your leg started working, and when you were kind of looking over that way, your leg kind of pushed out that way, and prefacing that with, I'm not saying this because I'm thinking you're faking it or anything like this, but actually understanding that that's how FND works. And this is what I'm actually seeing here. And what do you think about that? And asking them, opening that conversation up. Or if it's, in pediatrics, it's having that conversation with parents and explaining it to the kids as well in a way that they understand.
Yeah.
But going like, when you were really excited and you picked up that Nerf gun and shot it at the wall there, did you notice how your leg just moved? But, before when you were coming in the wheelchair, I could see that you were trying to move it, but it wouldn't move at all.
Yeah.
Now that's actually, that is the rule-in process for FND. That's like one of the main signs, is that when you shift your attention, symptoms reduce or function increases.
Yeah.
And that's wonderful. We can use that as part of the plan, part of rehab, part of, informing what you do in psychology or in OT, and how someone can get back to normal activities. So I think that's a big part of it, is saying it out loud in a way that is either curious or collaborative. I think is really helpful. Obviously, it can be said out loud in other ways, which then can cause kind of iatrogenic, or I suppose harm long term to someone's confidence and quality of life. But that can be that, like, oh, look, we've done all the tests, it's FND.
Yeah.
Which
there's nothing wrong.
Yeah, there's nothing wrong
Now we
with
think it's
FND.
Yeah.
Which ends up more likely to be interpreted as dismissing, and doesn't actually pose a plan moving forwards either, which can be less helpful.
Yeah. In terms of, I guess, if you were to kind of sum up the last little section that we've spoken about, is there anything that you would have as a bit of a, if you were to take anything away from this section, you would take this away?
I guess it's one is that there are lots of different moving parts with FND, or maybe not moving parts. But there's a lot of different moving parts which can make it quite complex. If you were to take away a couple of different things from this, is one that someone's body or nervous system isn't damaged. We understand that it's not damaged, but the function of it is impacted. So it's not working how we want it to be, and how that's explained to a person through that kind of diagnosis rule-in explanation pathways, really important. How that's done is really important. So taking the time with that, because it's a really important part of that kind of diagnosis journey.
I think if I'm remembering correctly about a survey we were talking about earlier, where they kind of surveyed, I think, about 500 people who had been diagnosed with FND, and only 10% of those reported that FND was explained to them at the point of diagnosis, and that they understood that explanation. And then 50% actually disagreed with that. So it's a lot of, a really high proportion of people come away from that without the experience that you described, which we know, which kind of leads us really nicely into our next section, we know can be such a huge vehicle for positive prognosis and positive change for people. So how do you think language shapes, people's kind of recovery journey or the trajectory of their FND journey?
Yeah, I think language And the words that are used across the board to do with FND is so important. I think it's like the backbone of recovery. Reason being is that the way someone understands what's going on with their symptoms then will help and inform how they respond to future symptoms and future experiences around that. So, if it's this, oh, look, we don't really know what's going on, it's FND, that the next time they experience those symptoms, they're going to approach it and experience it with potentially more distress and, unknown uncertainty on what to do. And so it can be quite challenging for clinicians and GPs and I guess like the whole allied health space in supporting someone when that language is not presented in a way that is collaborative. Yeah, and potentially, I suppose I'm cautious to say positive. It's not kind of being like, oh look, it's great, it's FND, but it's kind of going, this is what we understand, and this is what we can now do about it. It's kind of more pragmatic. Yeah. But yeah, look, I think that it's really, really important, the kind of words we use, and I think FND's been one that's even the words that are thrown around now. Yeah. Not thrown around, but continuously used, are kind of mixed, and that's probably based on the fact that it came from a space of hysteria historically. Yeah. Now we understand it a lot better.
We don't use terms like pseudo seizures anymore.
That's right. Yeah, pseudo seizures. I mean, it still probably is commonly used though. So I guess that's part of this podcast and kind of getting the word out there, and future PD in the space is going, okay, look, pseudo seizures, they're not the best terms. Non-epileptic seizures, even functional seizures, some people probably, they might not understand like what makes it functional. What does that mean? And I get that. Maybe non-epileptic seizures is a nice version for that, but then other ones, I guess, often people are put down to being like faking. They think it's faking if it says pseudo, right? And that makes sense. Yeah.
I was just thinking about what you were saying around language and how important that is, and thinking about kind of how much consideration we put in as a team when we work together around patients with FND in terms of using consistent language and consistent messaging, because I think often when families come to treatment for FND, the family system is usually really heightened. Like there's a lot of kind of, often there's a lot of stress and a lot of fear, rightly so, because they might have just had a child in hospital, undergoing all these investigations, these tests, and or they've been having, these dissociative attacks or non-epileptic seizures. And it's a really scary time for a lot of families, really stressful. Often they have to take time off work. Like there's just a lot going on. And so I think for us, we try and reduce the use of new terms throughout the treatment journey, because often for families, every new term is like, oh gosh, what's that? Is that something bad? Is that something I should worry about? And so I guess as teams, if you're working in a team, thinking about the consistency of language that you use across this space is really important.
Yeah, absolutely. And it depends on in a rural space as to what that team looks like, and understanding that team, a team of health professionals might be not quite at your fingertips. Yeah. But whoever is there, whether it be the GP and I guess even the family, that they understand the words that are being used, using the terminology that's kind of appropriate as well. I suppose sometimes we can, or I suppose a layperson may start calling the symptoms that they're having something that might be, like, I had maybe not a stroke, but, using terminology that spasticity is something that, physios we use, and you might see someone's muscles behaving as if it was like a spastic muscle and spasticity, but it's not. And so being really, quite specific about the words that are being used and making sure that they are, appropriate. So it might not be, okay, you've got the tremor and spasticity there, but rather going, oh, look, it's, your leg is shaking. Yeah. And part of that, as you said, there's that big fear response early on, or it's often a big experience for a family or person to go through the diagnosis and onset of symptoms, and so that helps to reduce the catastrophizing or the distress around the symptoms by using language that's more appropriate or accurately descriptive.
Yeah. Awesome. In terms of how you think about language shapes trust and engagement, what do you kind of, what would your thoughts be on how that does shape how a family kind of connects with you or engages with you?
Yeah, look, I think that it starts off on the right foot when it's kind of the right language is used, because they do develop an element of trust, and the way that it's explained to them can be really validating. And I think that often with FND, validation and that kind of building rapport and trust from the get-go is the most important thing at the start, because you can then move forwards and understand more about what's happened. And often with FND, it's number one, getting them to understand what's happening and what FND is, but then it's building that map of what's going on for them. And understand that for someone with FND, that it's not just that it's come out of nowhere. Yeah, there's things that we know that might predispose someone to experiencing functional symptoms, but also kind of precipitate the onset of that. Yeah. And so exploring those different things will only really be able to be done with an element of trust. And so, language from that get-go is super helpful.
Awesome. Should we move on to myths or?
Yeah, I think so.
Yeah. Okay. What would you say are the most common myths that clinicians still believe about FND?
Now, there's an interesting article that goes through kind of 10 top myths by Lyd Stone and Professor John Stone. So I would recommend from out of 2020 if you haven't read it before. That's a really nice one to have a look through. I'll touch on a couple there that are actually listed in that article. One being that, I suppose I'll go through them, probably the ones that I think are the most important. It's a diagnosis of exclusion only is the myth. So it's actually it can be ruled in and should be ruled in using things called positive signs. So I'll explain positive signs in a moment, but basically what used to happen is that kind of ruling out of everything and then going, okay, look, we've kind of emptied all the boxes, there's nothing there, there's no cancer, there's no stroke, there's no MS, a range of different kind of pathologies. It's FND. So that has now changed, where we're now looking at ruling things in, and that's from a doctor's kind of point of call, like a GP clinic, to ED, to kind of inpatient hospital, and then also for physios as well, who can kind of assess that and demonstrate it. Physios aren't able to provide a diagnosis of FND as it's through the DSM criteria, but being able to explain things through inclusion. So positive signs are moments where an individual's presentation is kind of inconsistent or incongruent with another different condition. So with that inconsistency, we would see that with an attention shift, symptoms wouldn't get just better. Yeah. So looking up on Neurosymptoms is a wonderful website that has a lot of different resources and demonstrations of things, such as the Hoover sign, where someone may not be able to lift their leg because of motor loss due to FND, but when they try to push out with the opposite leg while the other leg's being braced, it's quite hard to explain on a podcast. It causes an increase in function for a period of time, and that then rules things in. So that's one myth I'd like to kind of articulate as really, really important. Yeah. And then another one that's, we've already talked about is it's all psychological. We kind of understand that it's not. A portion of people do have experience trauma, but in the past it used to be that there must be trauma for everyone, and so there's actually a lot of patients that experience like a lot of questioning around what's gone wrong, what happened in your childhood, what happened in the past, when it can actually just be kind of the perfect storm of kind of physical stresses. Someone's unwell, there's a surgery, there's a whole range of different things, plus maybe some psychological stress or like an overload cognitively. So it's not all psychological, but it can be contributed to by psychological stresses. And the last one that I'll probably touch on is that it's voluntary. So, the idea that someone is putting on symptoms or malingering, or it's fictitious. And, that's probably worthwhile saying that there may be a very, very small percentage of that occurring. But really, that shouldn't really come into the question or equation, because I think it's more likely to be basically kind of presented in that kind of way. Might look like someone isn't meaning, I guess the nature of when someone shifts their attention off it, it makes it look like they're kind of consciously doing it. But that's just the nature of FND. So that's really important to note. And even sometimes explaining that to someone who feels particularly dismissed by other family members and being like, look, that's actually the nature of FND. Maybe you can explain it like this. There's some really important different myths to bust.
Busted. Consider them busted. I guess our kind of I guess something that also would be really helpful to talk a bit about is the role that early diagnosis plays. I guess we kind of see people at all different points in their journey. Typically when they come to a private practice and engage in our program, it's usually a bit later on in the journey. What would be the difference of having an early diagnosis? Like, what does that kind of look like in terms of prognosis for the patient or the client?
Yeah, so the evidence suggests an early diagnosis gives a more favourable prognosis. The reason for that may be that there hasn't been time for kind of motor pathways to be built, and kind of that kind of plasticity around kind of a different condition or kind of symptom. There's not that kind of ingraining of a certain kind of movement pattern, or the kind of forming into the nature. I'm saying habit, but not in the way of like it being a purposeful habit. The other part of it is that early on, someone's very less likely to have a lot of different experiences where they're not validated as well. So diagnosis is made early. A lot of those barriers, such as maybe seeing 10 different specialists or 10 different allied health before trying to get any progress. So there's been a lot less failed efforts, which then reduces barriers for progress. In terms of how important early diagnosis is, it's like one of, if not the most important thing when we're looking at acute FND presentations.
And I guess what we know as well is that kind of early diagnosis in combination with containment is enough to really significantly reduce symptoms. I think one of the stats that we have that's come out of ophthalmology is that with functional vision loss, that for, I think it was about 80 or 90% of children recovered their vision with reassurance from the ophthalmologist alone, which is pretty powerful when you really think about it. So what would that containment actually look like when you're in practice? Like how does one be containing at that point in someone's journey?
Yeah, and that's a really interesting stat. I think it is so powerful, and it is really helpful to use that containment. And containment, what we kind of think about is building a safe base for someone, so a safe medical base where they kind of understand, okay, like there's nothing else that could be going wrong at this point in time. So sometimes it is collaborating with like a GP or a doctor to do the necessary assessments, which might be ruling out like a couple of different things with general bloods, whatnot that would be appropriate to do, and also kind of if there are other different symptoms and there's uncertainty, referring on for investigations through kind of hospital or a neurologist. But I guess when we're looking at containment kind of early on, it's demonstrating those positive signs that I talked about before.
Yeah.
So going, look, we are seeing this. This is indicating FND.
Yeah.
I'm seeing these kind of, and explaining what a positive sign is even. So, I'm seeing these positive signs that is indicative of FND, which is a, software, hardware issue. You might go into that a bit more, kind of explain things. And with that provides an element of reassurance to, I guess, draw a line in the sand and go, look, this is what's happening for you. Let's now kind of move forwards. And part of it as well is providing a little bit of context to things too, and understanding that with FND, when someone's capacity is stretched or when there's certain stresses, whether they be social, emotional, physical, symptoms can fluctuate too. So, and that's containing in its own, saying, look, things may go up and down, even on the pathway of your rehab.
Yeah.
As you start to do more, naturally, that's more stress on your body. Symptoms might get worse at that point too. And that's really helpful from this kind of almost like airtight narrative for someone to understand what's going on. And if they do experience these kind of fluctuating symptoms, that's very common. The other thing is that symptoms sometimes change. New symptoms can pop up. If that does happen, it depends on the clinician and their skill set. But investigating those new symptoms is often needed, especially if that's new to the person, to provide that element of containment.
Yeah. So you can kind of confidently say, we're still really confident this is within the picture of FND.
Yeah, that's right.
Okay. Awesome.
So what we might ask now, and I might kind of flip the questioning over to you, Phoebe, to ask a few different questions to understand a little bit more about the mechanisms behind FND. So kind of how does FND develop? Because often we see that some people might present just with a very similar kind of narrative of potentially working with an adolescent. They're at school and they have exams and they get like really bad headaches, and it might be persistent headaches pop up. But for another person, they develop functional like motor disorder and their kind of legs stop working, or drop attacks. So I guess, how does, there's a few different parts to that kind of case or that narrative. But how does FND develop?
Well, I guess we might think about it in terms of the trigger model or perfect storm kind of framework of how FND kind of initially develops. And part of that is, I guess when we think about it, is a combination of all the kind of quote unquote right factors that lead to this onset of FND. So those tend to be that an individual might have existing predisposing factors. So when we talk about predisposing factors in a psychological sense, we're thinking about long-term kind of enduring stable factors like your genetics, like kind of your early childhood experiences, all of those kinds of things, early development. An example of that with FND might relate to the development of our nervous system. So we know in the first 1,000 days from pregnancy to about 2 to 3 years of age is where kind of 95% of our brain development occurs. And if we have things that occur that might disrupt that development or things that might mean that our nervous system's developed in a heightened way, like maternal stress or exposure to really difficult circumstances that increase our stress, our nervous system then, it develops in a way that is heightened, which makes us more vulnerable to something like FND developing later on, and that's kind of stable and enduring. And then obviously genetics. We don't know a lot about the genetic picture of FND, but we would likely think about it probably in similar terms to mental health. There might be certain kind of genetic makeups that might predispose us to being more likely to respond to stress in a certain way. And then often what we might see is kind of precipitating factors. So there are things that have happened that we kind of talk about being stressful. And when we say that, we don't mean just mentally stressful, but also, as Rowan said, kind of physically stressful. So it might be a really long period of training for a marathon, or doing an exceptionally long hours at work for a prolonged period of time. Anything that kind of starts to build what we would call like the allostatic load on our body, so that chronic kind of wear and tear stress load. And then, we might have some psychological components as well in terms of that. So kind of emotional situations that might occur, emotional factors, have like interpersonal conflict. Those kind of occurring across time and then combining at a certain point in time, we kind of get this individual vulnerability, and then we might get these things happen at a certain point in time. And that's kind of where we think about that early kind of diagnosis or that early intervention as being really important. I suppose we also kind of can see someone might experience one dissociative attack, and it's responded to with reassurance and containment and a really kind of consistent, solid medical team, and then we don't see that again. Mm-hmm. And that can look very different to the trajectory of someone else who develops FND over a period of time.
It sounds like it can be that kind of perfect storm, a lot of different factors and past factors or past experiences that kind of converge into this moment when someone experiences some sort of symptom and difficulty from that point onwards. But it makes sense that it's not not always just this one thing, but it's this slow burn from a number of different factors.
Absolutely.
Some were already there for a long period of time.
And we kind of this is purely anecdotal evidence, but often we kind of hear this story of where clients have kind of been living in this kind of almost unsustainable state for a period of time before FND. So it's like whether it's really stressful at home, or whether, as I said, it's really stressful at work, or whether there's been bullying going on at school, or whether they've been really pushing themselves physically. It's something that the body kind of eventually goes, we can't manage this level of load anymore. It's too much, in combination with those kind of other factors.
That makes sense. And I guess jumping ahead a little bit and into kind of linking in something that probably like plugs in quite nicely in this conversation is what predisposing factors, or I guess comorbidities or co-occurring conditions occur with FND, in the research, but as well as in experience.
So there's a probably quite a consistent profile that we might come across in terms of clients, and we often kind of, some of the things that we really commonly see, one that kind of jumps out at me straight away is a trait called alexithymia. And alexithymia refers to an individual's an individual who has significant difficulty identifying their emotional experience. We kind of often see that in combination with interoceptive difficulties. People who then have difficulty identifying their internal cues generally, so not just emotions but also hunger cues, their kind of physical cues, if they're tired, all of those kinds of things that that I guess people who are neurotypical who don't have interoceptive difficulties use throughout the day. And so often we see these kind of two difficulties impact how people who develop FND are able to, make sense of what's happening to them and how they're able to connect to those kind of symptoms and those experiences in their body. There's not a lot of understanding of exactly why that becomes so difficult, but I guess we kind of wonder whether it feels like more of a kind of foreign experience. It's interpreted as more kind of there's less agency for those symptoms. We know that kind of loss of agency is something that is a really big factor in what keeps FND going. It kind of people might start to feel like I'm powerless. I don't have any control over my body. I have no control over, whether I'm going to get better, all of those kinds of things on a really kind of subconscious level. And so potentially it's relating to that kind of disconnect with the body. I'm not entirely sure, but we do see that a lot. And kind of those factors then lead to a big overlap, which is between FND and being neurodivergent. So being autistic or having attention deficit hyperactivity disorder is a really common overlap that we see. And making sense of that is an interesting one. Again, there's not a huge amount of research, but we wonder whether it's kind of those two factors that I mentioned before, and then there's these individuals who are managing a higher allostatic load potentially because of that kind of increased sensitivity to sensory input and increased kind of perception of demand on being able to, go to school, keep up with interpersonal demands, keep up with family demands. And whether that increased load just makes people more vulnerable is kind of one way we might think about it.
That makes sense from the perspective of the perfect storm. If someone does have all those different demands or differences or kind of the way that they interpret sensory information. And I think that, their alexithymia and interoception are two interesting kind of components to it, especially when you kind of take that step back and think about how someone's interpreting their own kind of body experiences and what that kind of means for them, and I guess their ability to tune in to what's going on internally for themselves, and then different symptoms, and I guess then kind of register what's going on and when to stop too. For someone who has potentially neurodivergence or is neurodivergent, and a lot of the strengths of neurodivergence is being able to push past someone's own limits, whether that be physically with like running, like sports, or being really good at being able to push themselves when everyone else falls away. It's very rewarding, and the only thing is that someone can probably only hold that up for so long until they kind of burn out or their body stops themselves, and sometimes that could be an explanation for someone a way of describing what's happening as well and making sense of their experience of FND.
Absolutely.
You kind of talked a little bit about that kind of perfect storm and the stresses that might be going on for someone. I guess when we take, if we were to talk about the brain separately, how does the brain become stuck in some ways around FND, whether that be kind of predicting threat or stuck with its, the processes that are going on internally?
The model that kind of we like to refer to is the active inference model of FND, which kind of draws then, or is built on the predictive processing model. It's we think about FND as being a disorder or dysfunction of our predictive brain. So a lot of evidence suggests that our brain works on a day-to-day basis by predicting action and sensation, and then after that's predicted, checking whether that sensory input matches our prediction. This is something I would really recommend kind of researching yourself a little bit further because it's quite a complex concept, so I'll do my best to kind of go through it quickly. But I guess if we were to use the example of why why disorder or dysfunction might occur or how it might occur, we might use the phantom limb phenomena. So our brain predicts that the limb's still there because the limb's always been there from our prior experiences. That's all the brain kind of knows. And then even though there's kind of this bottom-up sensory input telling the brain there's no limb there anymore, the brain tries to reduce the error in its prediction by overriding the sensory input it's getting and kind of creating its own sensory input. So an example in functional visual loss may be that the brain is predicting that vision loss so strongly that it actually ignores visual input that it's getting in real time. So essentially the brain's trying its best to maintain that kind of homeostasis and reduce that prediction error by kind of favouring the prediction that it's predicted over the actual sensory input that it's getting. So it might be if someone, and a really good example that you can try at home is if, well, maybe don't try this at home, but if for example, a stovetop is really cold and someone goes to touch it and they think it's going to be hot, they'll pull their hand away, even though, and they might even experience pain, even though we know that it's actually a cold sensation. Our brain predicts so strongly that it's going to be hot that that's the input that our brain kind of favours, I suppose. What can then happen in this failure is that our brain forms that belief that what we experienced isn't based on real input. So it kind of thinks so strongly about it. And then the second failure that we get is that it then tries to explain the sensation that it's created as a symptom because the sensation that it's getting, the kind of physical sensation, because it doesn't match what it expected. So our brain is interpreting its own kind of wrong belief as a symptom. So for a person with FND, their brain goes, oh my gosh, what was that? There's something seriously wrong going on, which is kind of why we get this heightened state around symptoms as well.
Yeah, that's really well explained. I think that the phantom limb reference is particularly interesting for sometimes even clients or patients to hear about. Yeah. Obviously, to the depths that you just explained can be quite confusing. Yeah. However, kind of referencing, look, the sometimes our brain and body. And I think brain and body with this explanation is really helpful because it is the combination. Active inference is in particular the brain activating the body in response to create the sensory experience that matches its past experiences or its predictions, its ongoing predictions. So, the example there with the phantom limb, it's almost like the opposite of functional paralysis.
Yeah.
Or functional sensory change where someone might say, I can't actually feel my legs anymore. Yeah. But their legs are there. So it's like it's reverse phantom limb sensations where they've now predicted that, the legs are not functioning. Yeah. They're not potentially there or they're no longer interpreting sensory information from their legs, and often then paralysis follows. Yeah. And so what we might think about there is that an active inference process where it's creating the sensory experience that it's expecting, which is paralysis. Yeah, and
then the brain fails a second time to update and then interprets that as a symptom. So then kind of sounds the alarms of there's something going wrong.
Yeah, and then an element of distress comes into it, and that can make it quite challenging. But that key part is then the not updating past. Future predictions, of the past experiences. Now, what that might look like is, just being like, that's how it is. I can't, and this is probably subconscious, all these things we're talking about. Yeah. But then it could also be very much not subconscious where I can't get better. I can't do anything about it. But I think that the whole positive signs and demonstrating positive signs to the person is a really important part to this process because what you're actually opening up is an element of curiosity and potentially surprise. Yeah. We see surprise is actually learning. Yeah. So when someone goes, I can't feel my legs, I can't move them, but then we go through a Hoover's sign test and it comes back positive where they, when they distract themselves and look to the side and potentially even video that and show it back to them and go, look, actually, no, it did just move. They go, well, I thought that it didn't move. Yeah. No, it does. Well, it did. Interesting. I didn't expect that. And when, someone kind of has that moment of, it's kind of like chasing that aha moment. Yeah. Or that element of surprise. And that's where treatment comes from. Yeah. Or that process for rewiring or whatever words you like to use. So probably the last question I've got to ask here would be, what are the 3 most helpful things a rural clinician can do when they suspect FND, from your perspective?
Oh, great question. I think one is building your kind of professional confidence in managing FND is something that's really important. I think it's obviously quite a complex area, and I think because it's a complex area, people and clinicians might avoid working in the area because it feels so kind of in out of our depth. But kind of doing professional development learning, so doing some research. There's some amazing resources and articles out there, or potentially kind of seeking some supervision from someone who's really experienced can be really helpful. So I think that would be one. And also updating our knowledge. We do a lot of research a lot of the time because it's an area that's kind of ever evolving. So making sure, that you're feeling kind of confident in working in that space, or confident as you can be. I think the second thing would be looking at as Ro talked about, using that really kind of clear, helpful language to contain the patient or the client. Providing that kind of reassurance, and in doing so, reducing the stigma around FND, saying it out loud, it's okay, and talking about a bit of a plan going forward. And then I think looking at, okay, how can I get MDT support in helping this family with their FND treatment? So as Rose said, we work physio, psychology, OT. That tends to be a really helpful combination for most people. I think, at minimum, probably physio and psychology, and looking at referring to people who are experienced in the area, because often if people aren't experienced, it can be then another kind of, as you talked about, negative experience or failed effort the client kind of perceives. And so, getting someone who's familiar in the area and referring them and kind of keeping consistent communication with the treatment providers. I think those would be the things. Anything you would add?
No, I think that covers it really nicely. Maybe the one little kind of add-on is taking it seriously as well, and really understanding the person's perspective and how it's impacting them, especially if it has been going on for a long time. We kind of understand the evidence suggests the impact on quality of life is similar to someone who experiences stroke or MS or Parkinson's. So that kind of impact is really significant for people. And I guess kind of diving in and understanding what their perspective of things are is really important. And I guess that upskilling process you talked about, looking into the evidence, reaching out if you're not sure, always kind of even from a kind of peer-to-peer or mentoring perspective, we're really happy for you to reach out to us if you've got any extra questions on any of the information that we've kind of presented. If you'd like to hear a couple of different lived experiences or kind of recollection of lived experiences, we also run at Western Kids Health a podcast called Into the Invisible. We've talked to a number of different teenagers and young adults about their experiences on FND, as well as a few different other invisible conditions. So if you'd like to hear a little bit more about that kind of lived experience, that's a nice place to start. And it's been great to be on here at Rural Health West.
Thank you.